Good day everyone, I am Kelvin Abat together with Mr. Morena, Miss Capulas, Miss Evangelista, Miss Gandeza, and Miss Leal, and we are the reporters of Group 1. And for today, we would be talking about the pregnant woman with HIV infection. So 1/4 of the nearly 1 million people in the United States infected with this virus are female. The infection has become the leading cause of death in women 25 to 44 years of age. 1% to 2% of every 1,000 women giving birth are HIV positive. When the disorder is discovered during pregnancy, pregnancy does not appear to accelerate the progression of the disease. So the risk factors for contracting an HIV infection in women include multiple sexual partners of the individual or sexual partner, bisexual partners, and intravenous drug use by the individual or sexual partner.
For the assessment, unlike other sexually transmitted infections, HIV infection rarely begins with reproductive tract irritation. Instead, early symptoms are more subtle and often difficult to differentiate from those of their other diseases, or even from symptoms of early pregnancy. Examples are fatigue, anemia, diarrhea, and weight loss. Without therapy, HIV infection may progress through the following stages: the initial invasion of the virus, which may be accompanied by mild flu-like symptoms. Seroconversion, in which a woman converts from having no HIV antibodies in her blood serum or HIV serum negative to having antibodies against HIV serum positive. Seroconversion happens 6 weeks to 1 year after exposure. An asymptomatic period during which a woman appears to be disease-free except for symptoms such as weight loss and fatigue or a wasting syndrome. Although the virus can be replicating during this time, the length of this period varies but average 3 to 11 years. Asymptomatic period during which a woman develops opportunistic infection and possibly malignancies. Examples are toxoplasmosis, oral and vaginal candidiasis, gastrointestinal illness, herpes simplex, picarinea pneumonia or PCP, candida esophagitis, Kaposi sarcoma, and HIV-associated dementia. At this point, the CD4 count is usually below 200 cells cubic millimeter.
Although women are not as yet routinely screened for this infection during pregnancy, as a rule, no screening program is initiated for any disease until there is a cure for the disease. Women who practice high-risk sexual behavior should be asked if they want to be screened. A woman with HIV infection may also have contracted other STI such as syphilis, gonorrhea, chlamydia, and hepatitis B, and so should be screened for this as well. Because HIV-positive women are at higher risk for developing toxoplasmosis and cytomegalovirus infections. The health history should include questions about cat ownership, ingestion of raw meat, and recent mild flu-like symptoms. Ordinarily, toxoplasmosis presents with few symptoms. However, in the HIV-positive woman, it may invade the cerebrospinal fluid and cause extreme neurologic involvement. Tuberculosis also occurs at higher rate in HIV-positive people than in others and may worsen during pregnancy. So a test for tuberculosis should also be included.
If a woman is found to be HIV positive or has developed antibodies from having been exposed to the virus through an ELISA antibody reaction or an Western blot analysis, the issues of safer sex practices, testings of sexual contacts, continuation or termination of the pregnancy, and treatment during pregnancy need to be addressed. HIV infection is associated with low birth weight and preterm birth. About 20% to 50% of infants born to untreated HIV positive women will contract the virus and develop AIDS in the first year of life. However, if ZVD is administered to the woman beginning with the 14th week of pregnancy and the newborn receives antiviral therapy beginning with birth, the risk of developing AIDS falls below 10%.
For the therapeutic management, women who are identified as HIV positive are usually advised not to become pregnant until more is learned about how to prevent transmission to a fetus. Often, however, the existence of HIV is discovered only after pregnancy is already present. Progression of the disease is assessed by frequent CD4 cell counts and viral load levels during the coming months. A goal of therapy is to maintain the CD4 cell count at greater than 500 cells per cubic millimeter by administering, in addition to oral zidovudine, one or more protease inhibitors such as ritonavir, norvir, or indinavir, crixavan, in conjunction with nucleoside reverse transcriptase inhibitor or NRTI drug. If pneumocystis carinii pneumonia develops, a woman is treated with trimethoprim with sulfamethoxazole Bactrim, a combination drug not without consequences. As trimethoprim may be teratogenic in early pregnancy, sulfamethoxazole gantanol may lead to increased bilirubin levels in the newborn if administered late in pregnancy. Pentamidine pentam, the drug of choice for PCP in non-pregnant women, is yet another option.
Kaposis sarcoma, a rare malignancy that tends to occur with AIDS, is normally treated with chemotherapy. Chemotherapy is contraindicated during early pregnancy because of the potential for fetal injury but can be used later in pregnancy to halt these malignant growths. Thrombocytopenia may be present as part of the disease pathology or as a response to zidovudine therapy. This may make a woman a poor candidate for an epidural injection, for anesthesia during labor, or for episiotomy. She may need a platelet transfusion close to the birth to restore coagulation ability. To reduce the risk of mother to newborn transmission, women are offered the option of cesarean birth. Follow-up testing of newborns being treated with zidovudine for the first 6 weeks is important. If the child has 2 negative HIV cultures at 4 months of age, HIV infection can be reasonably excluded. For the nursing diagnosis, risk for infection related to dysfunction of the immune system secondary to invasion of HIV.
For the outcome evaluation, CD4 counts remain above 500 cubic millimeter and viral load less than 5,000 copies per ml and no symptoms of lung, vaginal, esophageal, or central nervous system infections are present. Pregnant women who have CD4 counts below 200 cubic millimeter may be prescribed drugs to help prevent opportunistic infections.
Such drugs include acyclovir or Zovirax for herpes simplex, clotrimazole traches or Miselex for oral thrush, parametamine or Daraprim, and sulfadiazine for toxoplasmosis, and trimethoprim with sulfamethoxazole or Bactrim for PCP. They may be immunized against pneumonia, influenza, and hepatitis B.
During pregnancy and at birth, active interventions are necessary to reduce the possibility of fetal exposure to maternal blood, often the mode of transmission to the fetus. Immunocentesis, for example, presents a risk for exposure to maternal blood and therefore is avoided, if at all possible, for diagnosing fetal maturity.
During labor, internal fetal monitors, scalp blood sampling, forceps, and vacuum extraction are avoided to prevent the creation of a source of bleeding. So, episiotomy also is avoided to limit this as possible blood source. So, although the risk may be lower than previously believed, breast milk can transmit HIV as breastfeeding also increases the incidence of mastitis in an immunosuppressed women. So women are advised not to breastfeed. So breastfeeding could also be exhausting for a debilitated woman. So women who are HIV positive need to be aware that they can still spread this illness through others via unprotected sexual relations. So nurses can help reduce the risk by providing patient education about the mode of HIV transmission and safer sex practice.
Healthcare Healthcare providers must use standard infection precautions to protect against the spread of HIV. This includes the use of gloves when there is a possibility of contact with body secretions, cover gowns if clothing will expose to secretions, and goggles at birth when there may be splashing of amniotic fluid. Gloves should be worn when handling the newborn until all maternal blood has been removed by a first bath. No blood sampling or injection should be completed on the neonatal until after a first bath and removal of maternal blood. Caring for a woman who is HIV positive during pregnancy and childbirth calls for great sensitivity to respect a woman as a patient with possibly fatal disease, while at the same time encouraging her to continue with prenatal care. Because research into the cause and treatment of this disease is ongoing. Recommendations constantly change. Nurses need to remain current on recommendations for therapy and prevention. That's all for the HIV infection in a pregnant woman. Have a good day and thank you.